Stable angina is chest discomfort caused by myocardial ischemia. It occurs when oxygen demand exceeds oxygen supply in the myocardium, usually due to fixed coronary artery narrowing. Significant coronary artery disease means 70% or greater stenosis in a major coronary artery, or 50% or greater stenosis in the left main coronary artery. The definition is important in exam questions. Diagnostic criteria of anginal pain. There are 3 classical features. 1. Constricting discomfort in the chest, neck, shoulders, jaw, or arms. 2. Precipitated by physical exertion. 3. Relieved by rest or glycerol trinitrate within 5 minutes. 3 out of 3 means typical angina.
2 of the 3 classical features define atypical chest pain of cardiac origin. If one or none of the features are present, the pain is classified as non-cardiac chest pain. Examiners frequently test this distinction. Now let us discuss features that make the diagnosis of stable angina less likely. Chest pain that is continuous or prolonged is unlikely to be due to coronary ischemia. Pain that is unrelated to physical exertion also makes a cardiac cause less probable. Pain that is triggered by breathing suggests a pleuritic origin rather than myocardial ischemia. Similarly, chest discomfort associated primarily with dizziness, palpitations, or difficulty swallowing is less typical of coronary disease. If the pain changes with position or worsens with deep inspiration, it is more likely to be non-cardiac in origin. These distinctions are frequently tested in the MRCP examination. Now let us discuss the causes of stable angina. The commonest cause is atherosclerosis. In this situation, a fixed coronary plaque, usually causing more than 70% narrowing of the artery, restricts blood flow during exertion. This creates a mismatch between oxygen supply and demand and produces the typical symptoms of effort-related chest pain due to coronary disease. However, not all cases are caused by atherosclerosis. There are important non-atherosclerotic causes that may present in a similar way. First, fixed outflow obstruction can increase myocardial oxygen demand. Examples include aortic stenosis and hypertrophic cardiomyopathy. Second, conditions that increase oxygen demand may provoke symptoms. These include thyrotoxicosis, anemia, tachyarrhythmias, and sepsis. Third, reduced oxygen delivery can also contribute. This may occur in hypoxemia or with carbon monoxide exposure. Coronary vasospasm is another cause. This includes variant coronary spasm and cocaine-induced vasospasm. Finally, structural or congenital abnormalities may be responsible. These include coronary artery anomalies, Kawasaki disease, and coronary damage following radiotherapy. In examination questions, chest pain due to coronary ischemia may be hidden within these alternative conditions, so always consider the broader differential. Now let us review the independent risk factors for coronary artery disease. The major risk factors include cigarette smoking, diabetes mellitus, hypertension, and dyslipidemia. A positive family history of coronary disease is also important. In addition, a history of established ischemic heart disease significantly increases future risk. In examination scenarios, always pause and actively identify these risk factors within the clinical vignette, because they strongly influence both probability assessment and management decisions. Now let us move to the diagnostic pathway. This is extremely important for the MRCP examination. The first step is to assess the typicality of the chest pain. Classify the pain as typical ischemic chest pain, atypical ischemic chest pain, or non-cardiac chest pain based on the 3 classical features. The second step is to rule out acute coronary syndrome. If the patient has pain at rest, rapidly progressive symptoms, or other high-risk features, Manage as acute coronary syndrome immediately. Initial investigations include a 12-lead electrocardiogram. Look for ST segment depression or T-wave inversion during symptoms. Remember that a normal electrocardiogram does not exclude stable coronary ischemia. If acute coronary syndrome is suspected, check high-sensitivity troponin. Echocardiography may reveal regional wall motion abnormalities or structural disease such as left ventricular hypertrophy. The third step is to screen for non-cardiac causes of chest pain. A chest X-ray may identify an enlarged aorta, rib fractures, or alternative thoracic pathology. The fourth step is the first-line diagnostic test. Computed tomography coronary angiography, abbreviated as CT coronary angiography, is now the first-line investigation for suspected stable coronary artery disease. Pretest probability scoring is no longer part of current NICE guidance. Exercise electrocardiography is no longer recommended for diagnosing new stable coronary disease. This point is frequently examined. CT coronary angiography has several advantages. It has high sensitivity and is an excellent rule-out test. It is non-invasive, provides three-dimensional imaging, and may identify alternative causes of chest pain. However, it also has limitations. It does not determine the functional significance of a lesion. It uses iodinated contrast, which carries a risk of allergy and nephropathy. It involves ionizing radiation. Image quality may be reduced in arrhythmias or heavy coronary calcification. If CT coronary angiography is positive or inconclusive, the next step is functional imaging. Functional imaging assesses myocardial ischemia rather than coronary anatomy. Options include stress echocardiography, stress perfusion cardiac magnetic resonance imaging, and nuclear perfusion scanning. Invasive coronary angiography is reserved for cases where non-invasive testing is inconclusive or demonstrates proximal or extensive disease. Functional imaging requires adequate stress, defined as at least 85% of the predicted maximal heart rate. Before stress echocardiography, beta blockers should be stopped 48 hours in advance if clinically safe. Caffeine should be avoided for 24 hours before adenosine or dipyridamole testing. Among the available options, stress echocardiography is preferred if the patient can exercise. Myocardial perfusion scanning involves radiation exposure and may have lower sensitivity in women. Stress perfusion cardiac magnetic resonance imaging uses adenosine with gadolinium contrast. It should be avoided in severe renal impairment. Claustrophobia may limit its use in a small number of patients. Now let us discuss the management of stable coronary artery disease presenting with effort-related chest pain. Management begins with lifestyle modification. Patients should be advised to follow a Mediterranean-style diet, rich in vegetables, fruits, whole grains, and healthy fats. Regular physical activity is recommended, aiming for daily exercise to the point of becoming slightly breathless, provided symptoms remain controlled. For immediate relief of chest discomfort, short-acting glyceryl trinitrate should be prescribed. It is used during acute episodes and can also be taken before planned exertion to prevent symptoms. Secondary prevention is essential in all patients. Low-dose aspirin, 75 mg once daily, should be prescribed unless contraindicated. If aspirin is not tolerated, clopidogrel can be used instead. A proton pump inhibitor should be added in patients with gastrointestinal risk factors. High-intensity statin therapy is required. Atorvastatin is commonly used, with the aim of achieving at least a 40% reduction in non-high-density lipoprotein cholesterol. An angiotensin-converting enzyme inhibitor, or an angiotensin receptor blocker if not tolerated, should be given to patients with diabetes, a history of myocardial infarction, or left ventricular dysfunction. These measures reduce future cardiovascular risk and improve long-term outcomes. Let us now move step by step through treatment for angina. We begin with first-line therapy. The initial treatment is either a beta blocker or a calcium channel blocker used alone. If the patient has had a previous myocardial infarction or has heart failure, a beta blocker is preferred because it improves survival. Whichever drug is chosen, the dose should be gradually increased to the maximum tolerated level. It is important not to combine a beta blocker with verapamil because this combination increases the risk of heart block and severe bradycardia. If symptoms of angina persist despite adequate first-line treatment, we move to second-line therapy. At this stage, you may either switch to the alternative class or combine a beta blocker with a dihydropyridine calcium channel blocker. If combination therapy is not tolerated or remains insufficient, additional drugs can be introduced. These include a long-acting nitrate, ivabradine, nicorandil, or ranolazine. If symptoms still remain uncontrolled, third-line therapy involves adding one of these drugs on top of existing treatment. However, triple therapy is generally reserved for patients who are awaiting revascularization. Now let us discuss revascularization. Revascularization should be considered if symptoms remain uncontrolled despite two appropriate drugs for angina, or if imaging demonstrates high-risk coronary anatomy. Coronary artery bypass grafting is indicated in significant left main disease, in three-vessel disease, or in two-vessel disease when there is left ventricular dysfunction or involvement of the left anterior descending artery. Let us now look more closely at the additional drug options used for symptom control. We begin with nitrates. Nitrates are commonly used to relieve chest discomfort due to myocardial ischemia. They work by releasing nitric oxide. Nitric oxide increases cyclic GMP in vascular smooth muscle, leading primarily to venodilation and some arteriolar dilation. This reduces preload and afterload, which lowers myocardial oxygen demand. Coronary blood flow may also improve through collateral dilation. Short-acting glycerol trinitrate is used for immediate relief and can also be taken before exertion to prevent symptoms. Long-acting preparations, such as isosorbide mononitrate, are used for ongoing symptom control. To prevent tolerance, nitrates must be prescribed with an asymmetric dosing schedule. This creates a daily nitrate-free interval of 10 to 14 hours. Common side effects include headache, flushing, hypotension, and reflex tachycardia. Nitrates must never be combined with phosphodiesterase 5 inhibitors, such as sildenafil, because of the risk of severe hypotension. Tolerance develops with continuous exposure, and this is prevented by maintaining the nitrate-free interval. Now let us move to ivabradine. Ivabradine selectively inhibits the IF current in the sinoatrial node. It lowers heart rate without affecting blood pressure or myocardial contractility. It should only be used in patients who are in sinus rhythm. In stable coronary disease with persistent symptoms, it is considered when beta blockers are contraindicated or not tolerated. In chronic heart failure, it is indicated in patients with New York Heart Association class 2 to 4 symptoms, sinus rhythm, a resting heart rate of 75 beats per minute or higher, and a left ventricular ejection fraction of 35% or less despite optimal therapy. Side effects include bradycardia, transient visual disturbances known as phosphenes, and headache. It is contraindicated in atrial fibrillation, heart block, marked bradycardia, or acute myocardial infarction. Next, nicorandil. Nicorandil has a dual mechanism of action. It has nitrate-like vasodilatory properties and also activates adenosine triphosphate-sensitive potassium channels. The overall effect is reduced preload and afterload with improved myocardial oxygen balance. It is used as a second-line option when beta blockers or calcium channel blockers are insufficient or unsuitable. Common side effects include headache and flushing. A serious adverse effect is oral or anal ulceration. If ulceration develops, the drug must be stopped immediately. It should not be combined with phosphodiesterase 5 inhibitors. Finally, ranolazine. Ranolazine inhibits the late inward sodium current in cardiac myocytes. This reduces intracellular calcium accumulation and decreases myocardial wall tension. Importantly, it does not significantly reduce heart rate or blood pressure. It is used as add-on therapy when symptoms persist despite standard treatment. Side effects include dizziness, constipation, and prolongation of the QT interval. MRCP, key points and exam traps. CT, coronary angiography, is the first-line investigation for suspected stable angina. Exercise electrocardiogram is no longer recommended for diagnosing new angina. Typical angina requires all three classical features. 70% stenosis defines significant coronary disease, and 50% applies to the left main coronary artery. Every patient should be prescribed short-acting glyceryl trinitrate for immediate relief. Avoid combining a beta blocker with verapamil because of the risk of heart block. Always include a daily nitrate-free interval to prevent tolerance. Ivabradine should only be used in patients who are in sinus rhythm. Coronary artery bypass grafting is indicated in significant left main disease or in three-vessel disease. A normal electrocardiogram does not exclude stable angina.